Thank you very much, and I hope what you saw is that building on some of the lessons that allowed us to reduce infections, we had valid measures, we had a systems approach, and we had peer review and the potential to expand that in healthcare. But yet, right now, I think the biggest indictment of our field is 15 years after this glorious report, we still cannot answer the question how many people died needlessly. I mean, I think that's just a stunning indictment of the work we have to do. Even the most common causes of harm, I think probably outside of infections, we don't have robust measures that the public could understand how we're doing. So, and there's really absent any verification system. So Scott, where would you guide us? Because I think we still need to have more standards for measures, and verification isn't part of our DNA right now.
Right. Well, there's actually good news here, as I mentioned earlier, that you can learn from various groups. Obviously, the accounting profession is one. One is on the measurement side. Information is information. And so the key thing, it ties back to the systems process. One of the first things you got to do is you got to develop the processes and systems to be able to collect the data on a current way. What we would suggest is creating a central group that could create some standards that people could have consensus about, so therefore hospitals could develop the mechanisms to be able to measure that. And again, there's a footprint out there to do that. So it's just a matter of the will to be able to do that. On the verification side, the accounting profession verifies all types of information. A lot of people say, well, the only thing you do is financial statements. Well, no, information's information. And so as long as whatever measures you write meet those 4 criteria that I mentioned earlier, that's why I mentioned them, actually, the accounting profession, the auditors are prepared today to be able to do that. Matter of fact, in certain areas, you could actually work with the American Institute of CPAs to be able to develop guidance to actually help auditors be able to do that. The reason I mentioned the various levels of services is you need to figure out who do you want to verify this information. Do you want it to be third party? Obviously, that increases the credibility of it, or do you want it to be maybe internally by internal audit or whatever? So you want to think about that. The other thing you may want to think about is you definitely want to crawl, walk, run on this. And so I would start focused and let it grow. Some people make the wrong decision of trying to make it perfect. Sometimes the perfect gets in the way of the good on this. And I would start small, and I'd work on it and work with the profession. But the good news is there's an infrastructure here. I'd leverage it.
I see we have some great questions. We'll start.
I don't think that the importance of integrating system engineering in healthcare, I don't think that can be overstated how important that's going to be moving forward. My question is about, in your Aegis system, obviously, this process starts from when it's on the drawing board. And in healthcare, we have a lot of existing systems, and I'd like you to touch on the challenges of doing this process with existing systems. Thank you.
Sure. Thank you for the question. That is actually part of what we do quite often. It is quite often that we're faced with a system that is not performing the way it was supposed to, had not gone through the rigorous process I talked about, and we actually have to do diagnostics to figure out why. And usually where we start is by going back to look at it holistically, and that is, what is it that this thing was intended to do in the first place? And we create what we call use cases, where we go out and we actually look at how is it intended to be used, what is it for, what is it supposed to do when it's doing that, and what are the outcomes that you want to come out of that? We call these design reference missions. And from that, we go and look at then, what are the no-kidding requirements for performance that this thing needs to do? And you write these requirements down, you state them explicitly. This is what this has to do. In these conditions, it gives you this response. In these conditions, it does the other thing. And so we're very, pedantic, if you will, going through understanding what it is it was supposed to do and the requirements associated with that. Then we do the assessment. Okay, let's look at the gaps associated with the current system. Why isn't it doing that? And that may take a little bit of experimentation, data collection, modeling and simulation and whatnot to figure it out. But usually we can root cause, what is it that is causing this thing not to achieve what we'd expected to do in the first place? And from there, then you go to concepts for solving those problems. You prove them out either through modeling and simulation or other proof of concept types of operations, prototyping if you need to do that. And then you turn around and you go to design and implementation. And when you finish design and implementation, you take it right back to testing. And we do test and evaluation. We test against the original requirements. If it falls short, we figure out why, and we go back and do it again. And Peter and I were talking about this earlier. This is not a one-time process, because once you're finished and you actually believe it meets the requirements you first intended for, and you field it, you suddenly realize in the field that, hey, I wanted something more, or I wanted something slightly different, or the threat changes, or the environment changes, or whatever it is you're trying to do is a little bit different. And we go back and iterate on this, and it's an iterative process that we go through as we try to do this.
Yeah.
Yes.
Well, on that, it's, one of the, I think, opportunities and risks is with this movement towards precision medicine in the beginning, the ability to measure genomics and proteomics. That potential, I think, will not be realized if we don't do this. We may just likely increase diagnostic errors because the complexity that is added by having breast cancer not be one disease, but a dozen disease without an information system to management, I think has enormous potential hazards. Chris?
Hi, Chris Castle from the National Quality Forum. I wanted to suggest that there's a connection here, and I think Peter was implicit in what you said, not only in needing national standards to make progress as a nation and to know what we're doing, but actually to give consistent and reliable information to consumers as well as to providers. And we heard earlier from Don Berwick and others about the kind of information overload and chaos and reporting fatigue and all of that is a result of our current sort of chaotic system. So some people, including Dr. Pronovost, have suggested a FASB-like model for setting standards in healthcare, and even suggested that NQF should be that entity. Not everybody's wild about that idea, so I'd be the first one to say that. On the other hand, NQF is, independent, transparent, and multi-stakeholder, and perhaps somebody else should do it. I'm quite intrigued by Scott's suggestion that maybe FASB would step in and do this for healthcare, because we have an industry, and I use that word intentionally, $3 trillion, where everybody has a vested interest in something, including now we have a quality industry. I mean, there's rankings and ratings industries. There's lots of people who are micro-optimizing within what they do, which is very good work, but it doesn't really give you that systematic national picture. So I don't know what the answer is. I'm not sure we have time for the panel to debate this, but I think that's Victor still sitting down front. And I want to suggest that this would be an ideal next study for Iowa National Academy of Medicine in the series to really take on this question of who should be setting standards. Thank you.
Well, great. And I may even add, Chris, to that also the verification piece, because again, we don't have any verification. The two parts might have to go together in this study.
So I want to take maybe a page from Mark Smith's sort of style and say, maybe the threat of having accountants actually be verifying healthcare would get everybody to agree on something.
It's a scary thought, isn't it? Yeah, I got it.
All right. Question.
Hi, Jeff Andrews. In healthcare, we have an expression, the near miss, which I was explaining to a friend a few weeks ago who's not in healthcare, and he looked at me and said, I don't know why you call it that. You should call it a near hit. Like we almost blew up the nuclear power plant. I'm wondering what you call near misses in your industry, how you detect them, and then what your response is if you detect one.
Did you want any one of the panelists to address that, or?
He was asking all three.
All of them if there's time, Peter.
Yeah, well, if you realize what we do, we're responsible. We have a lot of commonality. I didn't go into that, but is that when we screw up big. When you screw up, you kill someone, okay? So there's some similarities. If you look back at the major financial issues, people lose billions of dollars. And this is why the oversight board for us is not very tolerant about our errors. We have like a 99.9% rate, and that's not acceptable to them, okay? Because the problem is the 1/10 to 1%. It's big. People lose billions of dollars, and so that's what our oversight says. So our near misses would be when the financial statements would go out, or there not be disclosures in there that are appropriate. And where are they in the process? The firms internally have a lot of internal controls to catch this at various stages when you go through certain sections. So to us, it would be they almost got out. To us, a bad thing is a restatement, okay? When the statements go out and we have to restate the statements, and investors lose money on that. So us, a near miss is the statements almost getting out and there'd be an error in it. And matter of fact, that's an everyday occurrence. Our systems hopefully catch those types of things. But yeah, we do have near misses.
So in weapon systems, near misses are pretty apparent. And they can have devastating consequences. So for instance, this morning, at about 1 o'clock our time here, we launched a missile off the island Kauai from a system called Aegis Ashore. This is a system that's going to be fielded in Romania as part of the European phased adaptive approach, where we're defending Europe from potential threats like Iran and ballistic missiles from Iran. The shot today was taken against a target that was launched at sea, actually dropped out of the back of a C-17 at sea, traveled several thousand kilometers, and then was intercepted by the missile that we shot from the island. If we miss that threat, it lands on a city someplace. So our tests are rigorous, and we have to hit it within centimeters. It has to be precise. So we measure, we instrument, we measure, we analyze, and we're ruthless in getting rid of errors and mistakes that could preempt us or prevent us from actually being successful.
Yeah, likewise, if we screw up, you will know. So we do have near misses. Actually, we have a very low threshold for reporting something. In a normal nuclear power plant, anything that it is unusual, it is reported, stored in a database, analyzed, and regularly trended. So we have thousands of instances where we report everything. I heard this morning a gentleman from Texas say that some people were not reporting a broken door. That would never happen in a nuclear power plant, and we invite people to report everything. We analyze, and we are committed to give a feedback and action, keep it in a database, and trending regularly. If there are too many broken doors, there is something else wrong.
Jeff, one comment on that, because I think it's a confusion we have in healthcare, and that is separating from harms that are measured as rates versus those that we're not going to measure as rates. And I think we confuse those. I believe the major causes of preventable harm, like healthcare-acquired infections, like decubitus ulcers, should be measured as valid rates. They're common enough. We have clear definitions and numerators, and for most of those, we still don't have measures that we're comfortable with. The reporting stuff, where most of them are too rare, it's unlikely we're going to have a feasible way to measure rates. We need to reduce the risk, but I think the confusion is when we start reporting those non-based measures as they're giving us more information than they really are. In other words, we interpret them as rates. And I think a great way for us to focus might be on the top 10 major causes of preventable harm that we are well described, ensuring we have valid way to measure those.
My name is Julie Fairman. I'm from the University of Pennsylvania and chair of Biobehavioral Health Sciences there at the School of Nursing. Dr. Gordon, I really buy into your idea of integrated systems, especially in intensive care units, but I respectfully say your actors are wrong. The people who develop these systems and who work with them and apply them are really the nurses and the rest of the group around the bedside. Having said that, what about false alarms? We're seeing a lot of literature right now about alarm fatigue, and this really can lead to miscare or overcare, and it's really a quality and safety issue. So I would assume in your business and also in the nuclear business, how do you manage that, and how do you then make them, the alarms, part of an integrated system?
So I heard the statistics, and I'm not sure if this is exactly correct, but that in a normal ICU, an alarm goes off every 90 seconds?
Correct, and it's part of the study. Our nurses answer false alarms every 90 seconds, and we wonder why we haven't seen productivity gains from investments in information technology, because they're not wise.
So I guess my own personal experience, having been with family members in these settings, is that they largely get ignored after a while because they just know that they're false alarms. or they think they are. In weapon systems, we also have alarms, and at the consoles that this commanding officer and his crew man, they have alarms that go off with specifics associated with threats that present themselves or conditions of the ship that aren't what we want them to be. We have, again, very carefully tried to engineer that so that they're not so repetitive and so constant that they become overwhelming. Part of the way to eliminate alarms is to cross-correlate the systems that trigger those alarms. And what I mean by this is that if you have a threshold and you want to maintain a low threshold for an alarm with one particular sensor, if you can couple it with a second sensor that would recognize the same set of conditions and then actually look to see if both of them are showing that same condition before you trigger the alarm, you have some verification, and you do a lot to eliminate those false alarms. That, again, is part of this integration and system engineering of the overall system. But it's very important, then, that is fed back into however you display or transmit that information to the caregivers. And forgive me, I did not mean to imply any place. I kept saying caregivers. I just want to be broad about that. But we do want to make sure that the system, then, is not overwhelming them with these things. And so cross-correlation between different triggering mechanisms is one way to do that.
You know, if I could just add, when we were designing this eMERGE thing, one of the other APL engineers, Alan Ravitz, who's on our team, walked through and said, healthcare is the only industry where every monitor has its own alarm and they don't feed into some central integrated display. I mean, they said literally nobody would ever design it this way. It's too expensive, it's inefficient, and we have the system that we're designed to produce.
Yeah, also in the nuclear industry, obviously we have alarms. There is a strict procedure to respond to any alarm. We have hundreds of alarms. For each of them, we have a page, basically, of a response sheet. So apart the fact that the training for the operators, everybody needs to take the sheet relative to the alarm and read briefly what it is related and what actions he or she should take. And in case of spurious alarms, I would say there are very, very few, but in this case they would be considered not near misses, but instances that goes into the database and analyzed. And we do have a lot of integrations. We learned 36 years ago in 3 Mile Island, the accident that happened in the US, that one of the problems were too many alarms in the control room that distracted the operators that didn't understand what was happening. And so we worked a lot to improve the integration of different systems to give the right information.
Great.
Thanks very much. My name's Raj Agarwal. I'm a GI surgeon from McGill University. I'm really enjoying this panel, especially as a surgeon. I love technology. And my challenge is that you're very high technology industries, and we're talking a lot about technology. In healthcare, we have a concept called never events. And Peter, indeed, your team have published on surgical never events. And every year in the US, the last time you published this 2 years ago, there were 4,000 surgical never events at a cost of $1.3 billion. We have barcodes, we have checks, routine checks, checks over and over again, yet these thousands of never events are still happening. Retained sponges, retained instruments, wrong site surgery, wrong procedure. And my question, I have 2 questions if I may. Firstly, do you have a concept in your own industries of never events? And if you do, how do you deal with that? Because we're obviously not doing it very well. And secondly, related to that, in terms of, you've all talked a lot about technology, but how do we engage our carers, our healthcare staff, in using that technology appropriately?
Right. Comrade, perhaps before you answer, that your response, your question, and thank you, is often when people hear systems integration, they think you mean technology. And that, but what we mean is the people, the process, the leadership, the technology, all integrating together. And I think the problem we have is we think technology is a solution and we put it in without thinking about how, and the EMR is the best example, how it's going to impact workflow. And I know that's something we've discussed, Conrad.
Yes, it is. So an example I would give you is that the worst thing we can do is shoot down a friendly aircraft, meaning one that is ours or an ally's aircraft with one of our defensive missiles. And so ID, the identification of that thing, becomes very important. And what we found when we started analyzing, we have an operator in the actual Combat Information Center who's responsible for doing ID. When we started analyzing their job, we realized that they were doing over 1,200 button actions an hour. 1,200 button actions an hour. It just was overwhelming. And so, you know, no human can keep that pace for very long without wearing out, and that they were constantly being distracted by sets of information. So we were overwhelming them with information.
Sounds like a modern nurse.
It does. So as part of this holistic view, where you look at people, processes, and things, you start to look at distribution of responsibilities, that one person can't carry all those responsibilities anymore. And you look to see, one, can we augment them with some automation that would perhaps take away some of that need? But many times it's literally just redistribution of functional responsibility between the different people who are performing these things, then operating with automation to help them track those events that a person just doesn't need to do.
Jim?
Jim Battles from ARC. Also, truth be told, I'm a retired Navy captain, surface warfare. And one of the things that, of course, I love the pictures of the Aegis cruisers because I've got a son who's active duty Navy and is the technical action officer on Aegis cruisers and destroyers, et cetera. One of the things, we've had this conversation a little bit before, but one of the things is we look at, one of the challenges, and this is a concept that is pretty current in the military, is maintaining the bubble. You develop systems so that you can have an instant picture of what's going on. We don't have even the concept of, well, we sort of do, but not well developed, of maintaining the clinical bubble. Who is responsible for and what tools and resources do they need to maintain the clinical bubble, particularly in an ICU, ED? Who has the picture? Now, in the Navy, we used to give that job to the officer of the deck, and they were overwhelmed. We created a term of the tactical action officer, whose responsibility is to keep the big picture with all the other tools and resources. In a way, we need to create, and look where we do, for a clinical action officer, whether it's in OR, ED, and other. And then for the hospital, we need somebody who maintains that. And then the question is, what information in real time do you need to maintain that clinical bubble?
My son and I have had this discussion on many occasions. He's a anesthesiologist and critical care doctor who walks onto the ward, during rounds, and suddenly needs to know how 30 different patients are doing and assume care for them very quickly and for the next 30 hours or so. And as we talk about the process by which how that's done, again, I've been just utterly amazed, because I've spent my career developing systems that allow a commanding officer of a ship to walk into the CIC and within 30 seconds know exactly what's going on. And the displays and the information systems are cued to his needs, his specific needs, and are tailored to those specific needs, and to the point that we actually have them so that they can be tailored. And when the CO walks into the CIC, the displays all get, somebody hits a button and, it's the way he wants to see it. There's nothing that prevents us from doing something similar in information systems, so that a doctor who comes on the ward who is taking over care of patients can be informed of the history of that patient, where they are at in their current care, and what is the projected care that they should receive. There's nothing that prevents us from doing that. And I think actually Emerge has been working to do that.
All right, well, thank you. Again, I think our time is up. I'd like to thank the panelists and thank you for exploring this with us.